Welcome to the ACUR ANU student presentation session. I'd like to acknowledge and celebrate the first Australians whose traditional lands we meet on and pay my respects to elders past, present and future. I'm on Dharawal Nation land and I encourage everyone to think about the land that they're on today. So my name's Molly and I'll be chairing today's session. Our first presenter for today is Paige Goldman. So yeah, please start when you're ready. Take it away. Well, sorry, Paige, you're on mute still.
All right, how's that?
Perfect, that's great.
Well, good morning, everybody. As Molly said, my name is Paige Goldman and I'm a final year occupational therapy student at the University of Queensland. And today I will be sharing with you my research into the exploration of occupational therapy relaxation groups and understanding the patient experience. I would like to thank my fellow researchers, the individuals who assisted with running these inpatient groups, and of course the participants of the study. So today I join you from Kondamuka country, and I acknowledge the traditional owners and their custodianship on the lands in which we meet. I pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country. I recognise their valuable contributions to Australian and global society. So literature tells us that rehabilitation patients often experience increased levels of tension and anxiety due to the significant psychological adjustments required following an acute loss of independence and physical functioning. And whilst there is a body of research exploring the use of relaxation practice with specific population groups, for example, stroke and Parkinson's disease, there is limited research that explores the general rehabilitation patients and their perceived experience in group programs such as relaxation. So the development of a relaxation group was initially aimed at the reduction of tension and anxiety in rehabilitation patients. And the aims of this larger study focused on understanding the patient experience and its potential outcomes on their rehabilitation journey. Patients included in the study were residing on the rehabilitation ward at the Queen Elizabeth II Jubilee Hospital, a medium-sized metropolitan hospital located in Brisbane. The hospital offers an array of services, with patients being treated by a multidisciplinary team and have the opportunity to attend both individual and group therapy sessions, for example, the OT-delivered relaxation group. So the group ran for approximately 1 hour per week. As the group did not involve any strenuous exercise or really high levels of physical engagement, it was run in the afternoon and therefore did not interfere with any of the other therapies. The group was initially developed to be facilitated by occupational therapists. However, following a competency being completed, the OT assistants and students who were completing their placements were also able to facilitate the group. The group typically had 2 to 5 participants, and it was in a room that was large. It was a quiet space. It was able to be darkened and also able to have a door closed for privacy and for noise reduction. There was the use of meditative music, an essential oil diffuser, a small lamp, some battery-operated candles were used to assist with the ambience of the group. Meditation scripts were developed to include different ranges of relaxation techniques. So this including things like deep breathing, body scan, and guided imagery. So for the quantitative component of the study, participants were requested to fill out a tension rating scale, firstly prior to the commencement of being in the relaxation group, and then immediately post every session attended to the relaxation group. Participants, where possible, were encouraged to complete this independently. Tension was rating using a Likert scale, with 1 indicating the least tension and 6 indicating the most tension. And the difference between this pre and post relation group tension ratings was analysed using the Wilcoxon signed rank test, as participants were measured at 2 points in time using an ordinal scale. The qualitative data was then collected from participants following attendance at least 3 of the groups. Participants were purposely selected to represent a range of demographics and presenting conditions. Face-to-face interviews were conducted by a member of the research team who was not involved in facilitating or leading the groups. And these interviews were then transcribed verbatim and analysed through thematic analysis. So during the data collection, a total of 105 occasions of service were recorded with the pre and post tension rating scales, and this was produced for each occasion. The data for the interviews was collected with 10 individuals who completed that, and it's important to note that the demographics, whilst 67% of the participants of the relaxation group were female, 5 female were interviewed, 5 male were interviewed for the qualitative component. And the QE2 has a large cohort of geriatric medicine, with approximately 3/4 of the participants being over 70 years of age. Stroke was a predominant diagnosis, whilst there was a range of different diagnoses, and most participants attended between 1 to 2 sessions, with the most being 1 participant who actually attended 9. So there were 105 completed rating scales, as I mentioned before, and the Wilcoxon-Signed rank test revealed a statistically significant reduction in tension immediately following participation in the relaxation group. The mean score on the tension rating scale decreased from the pre-relaxation group being a mean deviation of 3 to the post-relaxation group mean deviation being 2. And it was observed that not a large number of participants had a high range of tension prior to the commencement in the group. However, there was still that statistical significant reduction in tension. So 2 key themes emerged from our qualitative data, this including outcomes of relaxation group, including mood, sleep, and ability to engage in rehabilitation, and the mood and ambient environment of the group. So the first theme was defined as the outcomes of the relaxation group, with majority of participants really identifying positive impacts on mood. But in addition to mood, it was also bodily functions such as sleep were noted to have a positive impact, with many participants commenting that they fell asleep either during the group or immediately following the group. And interestingly, relaxation group also identified to have a positive impact on ability to engage in rehabilitation, with 1 participant stating, "I went straight to physio after that, and it was the first time I walked 25 steps." So a common thread throughout the data was the expression of the positive impacts that were evident, even with participants who perceived themselves as actually finding it quite difficult to relax. Although the majority did report the impact of relaxation group being positive, it was not exclusively experienced by all, with 1 participant stating, "I was just bored senseless." So theme 2 summarises both the physical environment of the group as it feels like to attend. So majority of the participant responses promoted the idea that relaxation was this quiet and calm place, and 1 participant noting it was the one place that you can relax here. And more specifically, participants really described what the group was like. You know, they were sitting in a chair, their eyes were closed, the candles, the incense, there was low lighting, soft music. And it was noted on multiple occasions that the facilitator, using a quiet and calming tone, really ensured a relaxing atmosphere. So interesting, there was some differing opinions though in the engagement of the group, with 1 participant saying it was quiet and, you know, winding down, where 1 participant actually said they would have preferred if people could communicate more in the group. So what does this mean? In summary, relaxation group indicated statistically significant change in tension and anxiety, as well as positive outcomes for the enjoyment of patients. So it supports the use to have this within the inpatient rehabilitation setting. The findings also provide recommendations for clinical practice and for future relaxation group implementations in rehab settings. So this firstly including the consideration of that physical environment, so ensuring that soft lighting and having a quiet space and engaging with appropriate stimuli like visual and auditory and olfactory stimulus. The importance of having a facilitator using a calming and quiet tone is recommended for practice. And also finally, where possible, gaining that consumer preference for types of meditation, such as guided imagery versus body scans prior to actually starting the group. So although this study did provide valuable insight into the patient experience of relaxation groups and its impact on tension and anxiety, it was taken from a single site and a small sample size, highlighting the limitations of the research. So whilst looking at future research, there's an opportunity to explore the long-term use of relaxation strategies post-discharge, as well as consideration into the different modes of relaxation deliveries, whether that looks at an individual session or a group session, and understanding the barriers of each. And finally, from a clinical perspective, it's identifying whether patients prefer that facilitator-led approach, like we took in this study, or a peer support style where there's engagement of conversation around anxiety and tension and relaxation experienced by patients whilst being an inpatient on a ward. And seeing what provides better outcomes, that would also be an area of further interest for research. So I thank you very much for your attention this morning. And if there's any questions, feel free to ask away.
Awesome, thanks Paige. That sounds like really useful research and it was really well presented. So if any of the attendees, we actually have quite a few now, which is really great. If you would like to put any of the questions into the chat, I can read them aloud. But if not, if the judges have any questions, take it away.
Yes, I have a question, if I may. First, Paige, thank you so much for this beautiful presentation. Very well done. I would like to point out you have a beautiful speech pattern. It was so easy to follow you, and I know that we are usually very nervous when we present. So very well done. Pace where you're talking, you're very clear. It was very succinct. Very well done. I also like that you pointed out the limitations of your study, which is great. I have one question, which is around the recruitment. I was wondering how many people in overall you were approaching and how many of those that you approached were eventually recruited into participating in the study.
Yeah, so within the ward, it's actually based on referrals into the groups from the occupational therapists. So it is quite, number limited in regards to only having those 2 to 5 participants per each group. And that gets updated kind of each week to see who we need to have in these relaxation groups. So it's selected based off the OTs identifying that need. There's not an area for self-referral yet from the patients. So it is quite purposeful selection of kind of the 5 inpatients that need relaxation training kind of for that week.
So all the patients that were referred were eventually selected to participate and chose to participate in the study?
Yes, so we had 105 that did that quantitative section, and then we purposeful just selected 10 of that who agreed to do the qualitative component of the study and do the interviews.
Great, thank you.
I can't see any questions in the question and answer section or in the chat. We do have like 2 extra minutes if another judge had another question.
Yeah, I have a question for you. Thank you very much for your very nice and clear presentation. Can I ask, can you please explain the ethical consideration of your research?
Yeah, definitely. So definitely getting all the ethical, clearance was really important for a study. And I think knowing that it was, with that mixed methods of having our majority of participants, and the inpatients getting to do that quantitative, that independent fill out of the survey. But then we did have that qualitative side. And I think it's really nice to kind of highlight how we went about doing that and having a researcher that wasn't involved in the delivery of the groups at the hospital, or who wasn't a member of the OT team at the hospital, an external researcher who was at the University of Queensland to actually conduct those interviews was really important, and probably one of the important things, especially coming from that occupational therapy point of view, of getting to have that freedom and that ability for people to speak their mind and actually say what they want without any hindrance in regards to who was conducting the interview. So that was definitely something that was a kind of ethical consideration that we really took into consideration going into the project.
Perfect, thank you.
Awesome. So thanks, Paige. We probably don't have any more time for questions, sorry. But if people have them, put them in the chat. Maybe we'll have time later, or feel free to contact Paige.
Thank you.
Yeah.
Thanks, everyone.
Awesome. So unfortunately, our next speaker isn't here yet, so we'll just keep it rolling. So I'd like to introduce our next speaker. So up next, we have Courtney Muir. So take it away.
Thank you. I'll just get my screen ready. Okay. So
Yeah, that looks good. So take it away.
perfect. Thank you. Okay, so today I'm going to be talking about the effects of family accommodation on later life. And specifically, I want to show that there is a relationship between family accommodation and geriatric anxiety. And I do want to just firstly also just thank my supervisors, Dr. Carly Jonko and Professor Viviana Woodbridge, for all their help on the study. And to start, I just want to go over why do we want to study older adults and why is it important to look at anxiety in older adults. And one of the main reasons is that anxiety is actually one of the most common mental health issues affecting older adults. And there's been research to show that it actually reduces quality of life and it can increase the risk for suicide, cardiovascular disease, cancer, dementia, and even increase the earlier onset of disability. And despite all these findings, the mechanisms that actually maintain anxiety in late life are not well understood. And there actually is a lack of specific treatments that look at late life anxiety, and there's no treatments that really specifically target the maintenance of anxiety in later life. So one of the ways that we have been thinking about to kind of explain the maintenance of anxiety in later life is called family accommodation. And family accommodation is the ways in which a loved one participates in a person's anxiety. So for example, if I was really scared of dogs and my partner maybe always locked up a dog whenever I went to a friend's house, or made sure that there was never a dog whenever I went to a park, even though my partner would be helping my anxiety in that moment, he's actually participating in family accommodation through avoidance. So he's helping me avoid the things that make me anxious. And this leads me to talk about why do we care about family accommodation? Well, these behaviours actually maintain or increase anxiety. And we've also seen that family accommodation can even create pressure and a burden on the person providing family accommodation. And these kind of behaviours we see are avoidance, intrusiveness, or even excessive reassurance from the supporter. And then despite all of this, it's never been researched in later life. So previous literature has actually focused on children and young adults, and we've seen three main things. First, accommodation is very common in children, with 86 to 100% of parents with children with anxiety actually showing some form of accommodation. And they even do it about 60 to 80% of people actually do it every day. The second thing we've seen is that accommodation is actually related to anxiety. And we see that providing accommodation actually increases or even kind of maintains anxiety, because a person with anxiety never gets to learn how to regulate their own emotions or actually learn what they're afraid of probably isn't as bad as they think it is. So bringing it back to that example with the dog, if my partner was always helping me avoid dogs, I would never actually get to learn how to deal with those anxiety emotions. So then my anxiety would just get worse and worse and worse as I get older. And the third thing we've seen from children and young adults is accommodation is actually related to distress. And supporters take on a huge amount of pressure when they accommodate. They have to change their daily functionings. They have to change all their modification of their days. And they've also seen, even in PTSD literature, that accommodation is related to relationship problems. So now we think, well, why can't we use all this research we see in younger populations and just kind of use it in the older generations? Well, there's a few things. So first thing is geriatric anxiety actually has a high comorbidity with a lot of medical conditions. Second thing is a lot of older people need support, physical support or carers. And then the third thing is we do not know the effects of age and disability on family accommodation. So obviously you can see there are a few differences between younger populations and older populations that we're just not really sure of how family accommodation will kind of transfer. So that brings me to my current study that I conducted. And I asked two main questions. One, what types of family accommodation occur in older adults? And two, is there a relationship between the increased participant anxiety and then the frequency and intensity of accommodation in older adults? So to do this, I recruited 32 dyads. So we had a participant and then their supporter. The supporter was mainly partners and adult children, but we sometimes also saw neighbours and friends as well in this study. And we had, for the mean age for participants, it was 70, and the mean age for supporters were about 49. And for each group, we had 19 females in each. And the participants, the dyads, were asked to do questionnaires. So first we looked at the participants and they were asked about the anxiety, depression, and also we used a measure called the instrumental activities of daily life. And this was looking at participant functioning. So they were asked questions like, can you do your shopping by yourself or do you need support? So trying to look at that effect of support and disability. And then the supporter did a questionnaire we call the DAS. So that's a depression, anxiety, and stress scale. And they also were asked questions on the family accommodation scale, which was interviewer rated. And we looked at two subscales of that. First, we looked at participation in accommodation. So supporters were asked, did they participate in accommodation? For example, did they do reassurance? Did they help avoid those type of behaviours? And then they were also asked about their modification. So they were asked, did you have to change your work schedule? Do you have to change your leisure activities? And to what degree as well? Then we also completed behavioural tasks, and we decided to do a behavioural task because in previous literature, it's really been focused on self-report accommodation. We hardly see kind of the observer-reported accommodation. So we wanted to see whether there was anything different. So they did a speech task in an attempt to try to induce anxiety. So we told the participants that their speech would be recorded and shown to researchers who would be analysing how well they did, and they'd be ranked and they'd be giving a score. And we also told them that the speech was a good measure of their cognitive ability. So if they didn't do very well, then there's something wrong with their cognitive ability. And taking from previous research, we coded on a few behaviours. So we looked at the frequency and intensity of supporter intrusiveness. So how much a supporter took over the task or told the participant what to do. Supporter avoidance, which was how much the supporter kind of helped them avoid or encouraged them to avoid, saying, oh, don't do this, you can just take a break or something like that. And then supporter reassurance, so how much they might have said, oh, you're doing really well, keep going. And that brings me to my results. So we looked at first the family accommodation scale, which was our interview questions that we asked. And we saw that the most common behaviours that supporters reported were providing reassurance and also participating in behaviours related to their loved one's anxiety. For example, some people mentioned that they might make phone calls for their loved one because they were too anxious to do it themselves. We also found that the loved one's anxiety actually became worse when accommodation was not provided. And that the supporters even reported that they became distressed when they did provide accommodation. Then we also looked at the most common behaviours in the behavioural task. And we saw that the most common was actually supporter intrusiveness. So that supporter kind of coming in and doing the task for the participant. Then we decided to also look at some correlations. So there are three main correlations here. So the first one is the participant anxiety against supporter intrusiveness, which was significant. And also participant anxiety against the family accommodation scale participation, which was significant. So there was a relationship there. And then also there was no significant correlation between participant anxiety and the modification scale. So then we also did regressions, which were looking at the participant anxiety, supporter anxiety, and participant functioning. And we found that there was a significant, participant anxiety was a significant predictor of participation in accommodation. And it explained about 24%. So as participant anxiety went up, participation in accommodation went up. Then we saw that supporter intrusiveness in the behavioural task was also, participant anxiety was also a significant predictor there. But again, modification was not. So as participant anxiety went up, the modification of supporters did not go up. So finally, that leads me to, what does this mean? Well, we see that family accommodation is related to older adults. There is a relationship there. And that could possibly mean that maybe future treatments might need to consider the kind of relationship that a family member might play in the maintenance of anxiety in older adults. And we also want to see whether maybe support intrusiveness is the main part that's having that impact. So further research does need to be done just to see that research, definitely because this was the first study to ever look at it. And I just want to quickly show these are my references, and thank you all for listening. And if you have any questions, I'd be happy to answer. Thank you.
Awesome, thank you. That was so interesting. So again, please put your questions in the chat for the audience. And if not, judges, if you have any questions.
Okay, I'll go first again. Courtney, thank you so much for your presentation. It is really evident how you're passionate for this topic, which is fantastic. And I can see that you've done a big project, which is very fascinating as well, and a great justification for your project. It was very clear why this research was necessary and why you thought it was important to do this. You also noted that we can't just rely on the literature we already have, we need to conduct new research. So I was wondering if during the course of your research, you encountered any surprises, anything that you found in the data where you personally thought, oh, well, that surprises me, I did not see that coming.
Yes, I actually did. So we see in a lot of children, like I quickly highlighted about how the parents of children with anxiety always really report a high amount of distress and a high amount of modification. And then when we looked at all the older adult data, we actually saw that it was only about 22% of our data that reported any distress. And also there was no relationship with any modification of daily activities, even with those more anxious participants. And this was really surprising because I expected there to be some type of modification or some type of distress, definitely when we are seeing that older adults are accommodating. And one of the reasons why I think this might be happening is because a lot of the people that we looked at were long-term relationships or adult parents. And after accommodating someone for so long and for so many years, possibly they could have been together for 30 years, accommodating that person for 30 years, by the time you get to 30 years later, you probably don't realize how much you are modifying. It becomes the norm. Family accommodation becomes the norm for them. So in later life kind of accommodation and anxiety, the people that are accommodating are probably just used to it. So they don't report distress and they don't report any kind of modification because they don't see it. Whereas in children, you've just had a baby or a child or young child and you aren't used to accommodating and now you have to do it all the time. So that's why I hypothesize that that effect is probably happening.
Thank you.
Great. Does the other judge have another question? And then if not, we'll go to the chat where we have a question in there.
No question. Thank you very much. It was really good. Thank you.
Awesome. So our first question comes from someone in the audience who says they're a nurse in acute geriatrics, and we see quite a lot of family breakdown. Do any of your participants experience cognitive decline that exuberated their depression or anxiety?
Yes, so for my study, everyone was actually screened first to see if there was any cognitive decline, and they had to actually pass a certain amount of questions to be able to put into the study. And we also did do a measure looking at family dysfunctioning. So it's quite a well-known kind of measure that people use. It's the McMaster's family device, and we looked at the general functioning of the relationships, and they actually had to report how much they thought their relationship was working and whether they could kind of talk to each other about issues. And so we didn't, first to kind of address the cognitive decline, we didn't have anyone in our study that did have any significant cognitive decline. And we decided to do that just because this is the first study, we wanted to try to make it as controlled as possible, and including people with cognitive decline could possibly kind of bring up more of a relationship with this disability rather than anxiety. And then with the family functioning or decline in family functioning, we actually no one really reported any significant family dysfunctioning or relationship dysfunctioning. So we can't really, from my study, we can't really see whether there's any that kind of relationship with cognitive decline or family breakdown or even increased anxiety.
Awesome. So we're supposed to have a third presenter, unfortunately, and I can't see them anywhere. If any of the attendants in the chat are friends with them, feel free to message me, but I don't have their contact details, so there's nothing I can do. I just hope they're okay, and yeah, I hope they're not missing out. Yeah, so I guess we have 15 minutes to spare. I'd like to open it up and just have a discussion, I guess, and use this time. Yeah, any questions for Courtney or Paige in the audience, or judges or anything like that. Yeah, and please message me if you know why they're not here and if I can help in any way. The third presenter. I guess my question would be, both of you had really, really big studies that were really amazing, and what was sort of the time frames for that? Was that an honors year where you did all that, or have you been working on it for a while? And I guess, yeah, for both of you.
Well, for my study, yeah, it's an honours project. So I'm in my honours year right now, so I just got the results about maybe a month ago. So yeah, so it's quite a short. We did it quite quickly. That's why we only really had 32 dyads. But yeah, so mine was just an honours project.
Awesome, very impressive honours. I guess, yeah, Paige, if you had an answer too.
Yeah. So my this research was part of at the University of Queensland, there's summer and winter kind of research programs that they run. So this was kind of my first taste of research last year during the winter period. So just over 12 months ago that I got to do this project for. And it's a really great way because that then really sparked my interest in research. So I then went on to do a summer scholarship over summer just gone, and then I chose the research stream for my final year of OT. You can do an honours research stream, and I chose to do that. So I'm currently working on another project team for my honours year. But yeah, it was a really great opportunity just to see what research is like, and then to get to have the ability to get to kind of present what you find is wonderful too.
Awesome. Yeah, I did a summer research myself, and it really gives you that taste, and then you're can see where you can go with it. And yeah, at UQ as well, they have a great program.
Yeah, they do. Yeah, a way that you can kind of get a taste and still feel really supportive in established research teams. Yeah, I'm definitely.
Yeah. And definitely. I really liked the training, the employability center and all that.
Yeah. There's heaps that you have access to. It's yeah.
It definitely made my decision for staying in research.
Yeah. No, it's a great opportunity.
Anyone wants to jump in? And
well,
even sorry.
I just wanted to say it's great to hear that you got booked by research. I was wondering what both of your plans were after this research, whether you would continue researching in this area, or whether you just finished those projects and now will move on to different areas, different projects in your life.
Yeah, well, so my degree is doing honours in psychology. So what I want to do is hopefully next year do a clinical master's, but with a focus. So we also do a research project in the clinical master's program as well. And I will continue kind of looking at older adults, and hopefully with the long-term view of finally being able to work as a clinician in helping older adults specifically, maybe with that maintenance of anxiety, and hopefully using some of this research in many years to come to be a clinical psychologist.
Awesome. I love that it has that practical side to it, because that's what makes research great.
Yeah, and I think I'm quite, similar to Courtney, getting to do this research has been great. And, as I approach graduation kind of come November, I'm really interested in kind of hospital OT where these groups are run. So even on my placements that I've had this year, getting to be involved in facilitating these groups and having had a background in actually doing some research into groups programs within inpatient wards has been amazing and has really helped, you know, to see that link with the clinical skills. So at this stage, I'm kind of looking to go out and practice for a bit. But I do think kind of research is always going to have a bit of a space in my heart, I think. I think it's something that I'm definitely going to come back to, because it kind of, you finish one project and it always kind of leaves you wanting a bit more and you keep going. So so I think that's kind of my direction and a bit of the plan going forward.
Yeah, that's awesome to hear. I'm in a completely different field, but for me, the way I see it is like, they're not separate. You dip in and out, definitely. Yeah, any more questions? I just put in the chat, like, if there's any undergrads here that like haven't done honors or anything like summer research related, you know, this might be a good chance. If you're interested in like clinical stuff or, yeah.
And I guess like a bit of advice, if there are any undergrads listening or something, like a plug for the research scholarship programs or things that you can do. I never thought I would be really interested in research. And then with everything that happened last year with COVID and that, I was like, you know what, for my holidays, I'm going to be home anyway. I may as well join a research team and just give this a go. And, you know, it really opened my eyes. And since then, I've got to present, you know, my research at different national conferences and, you know, get to share a lot of different things. So I kind of, you know, a bit of a pitch, but if you ever get the opportunity to kind of go for it, and you never know what opportunities it can lead to.
Yeah, no, that's great to hear. Yeah, no, I have a lot of praise for the summer researchers programs. Yeah, I know there's great ones at ANU. I know there's great ones in Sydney and stuff like that, in Wollongong and stuff. So yeah, they're really great. And like, even if you don't think it, like the skills you get, and if you leave research, it doesn't matter because the skills are so good. Yeah, I can't see any other questions. I just feel so bad for the other person that's supposed to present. I hope they're okay. We have until 1:45, so if you want to go, you don't have to stay. Judges, if you're busy. But yeah. Are most people in the chat in this area or different disciplines? I know it could be a bit hard asking questions. I had a conference this week, and yeah, when everyone's an expert, it can be really intimidating. So I totally get it. But I'm sure everyone wouldn't mind, you know, if you want to send an email, stuff like that. That can always be nice if you're too scared to. Well, not too scared, but not wanting to. Do judges have anything to add? Anything?
No, nothing to add. Just thank you very much for sharing your research. That's been wonderful. It's very inspiring to listen to you, especially since you're early in your career. It's very fascinating. I will indeed then leave the chat already, if that is fine, because we have to complete those forms online. That's okay, Molly?
Yeah, of course. Yeah, that's why I said, I'm like, take the time you need.
Lovely. Then all the best to the both of you, and to you as well, Molly.
Oh, thank you.
Thank you. Thanks so much for today.
Great questions. Yeah, if we want, I reckon I'll just give us an early mark. But yeah, thank you to both. You did great. And I'm really glad we had an audience, because sometimes, because there's so many small sessions at this conference, like we don't get much of a turnout. I presented 2 years ago, like in person, and no one came. So yeah, so I'll just end the session, and you should be able to reconnect to next sessions. But
Thanks,
you know,
Molly.
all the
Thanks
best. Yeah, no, and congratulations. It was great presentations.
Thank you.
Good job, Courtney.
Thanks, you too, Paige.
Thank you. All the best.
Thanks. Bye.